I'm Pui Kwok, professor of dermatology and genetics at the University of California, San Francisco, and director of the Institute of Biomedical Sciences at the Academia Sinica in Taiwan. Well, I got into genomics by accident. I started out wanting to study the active ingredients that made Chinese herbal medicine work. But when I got to Washington University in St. Louis to start my postdoc, I got the opportunity to work with the leading figures of the Human Genome Project, and I joined Maynard Olson's lab to look at human variation, and that's how I got into it. So 5 years ago, I had the opportunity to come to Taiwan, and at the time, I decided that instead of doing genome-wide association studies to look for biomarkers and so forth, I want to actually apply predictive genomics in a population for the patient. So I think of this as the three A's: assessment, making the disease prediction for risk; advice, giving them the right guidelines optimal for their conditions; and act. So to act on these advice so that they actually can do healthy living and leading to longer health span. So we started enrolling 1 million people in Taiwan who are genetically very similar to each other, meaning 96% of the population here are Han Chinese. And so these participants actually give us access to their comprehensive clinical record and a sample for genetic profile. When we started this project, we actually have two separate sets of tests that we want to do. So one has to be the genetic testing of all the known risk variants that have been published thus far. And then the other is to generate the genetic profiles of the Han Chinese. So in that, we needed a technology that gives us the flexibility to customize the marker set that we use. And so that's how we got into using the Applied Biosystems technologies, because of its flexibility to put in the specific markers that we want. And so we're able to work with the team that helps us not only design the array, but also make sure that some of these really important markers have good coverage or duplicated coverage so that we always get a good and accurate answer. So we chose microarrays over, say, whole genome sequencing because of two reasons. One is that it's way too expensive and it's much longer process to do sequencing rather than microarrays. The second is actually more conceptual, in that if we have 3 billion bases for each person, we actually cannot interpret it so well. So in the end, if we want to do kind of a population-based analysis, we still have to distill it down to the markers that are of appreciable allele frequency in the population. So in the end, we still have to distill it down to a smaller set of markers. So microarray actually gives us that edge. Not only is it cheaper and faster, but also the analysis is a lot simpler, I would say, and make us able to use profiles rather than individual alleles for the analysis. There are many challenges for a project of this size, but for me, the major problem is actually conceptual. Most researchers want to find biomarkers, predictors of conditions, but very few want to do this as a patient-centric project. And so what we really want to do is to make this work for the patient's health, not just some scientific discovery that we can publish. And it's really difficult to explain to people that somehow this magical predictor will help advance our health. So this will take some time to kind of prove it to the world that using a genetic risk-based model of delivering healthcare is viable.